This program was brought to you by Koller Institute of Venture at Tel Aviv University.
Hello everybody, my name is Uri and I belong to the Department of Biomedical Engineering here in Tel Aviv University, as well as the Sagol School of Neuroscience. And one of the things that we know when we study diseases of the brain is that we have such a deep misknowledge or such a deep lack of knowledge that we can't wait for the research to do everything in the pace of research, and we must come up with solutions that will aid patients. And we came up with a small idea of trying to solve some of the problems, or main problem is related to mental health patients by the use of smartphones and by building a system that is based on smartphone gathered data. So, well, probably everybody in the crowd knows a mental health, a mental patient. And the disease is really a horrible disease. It's a chronic disease. It has a relapsing remitting pattern. The patient might have one bipolar episode, and then he lives happily for half a year, and then the thing returns. And the end of the second episode can be a suicidal act. In many cases, the patients don't respond to treatment or don't want to take treatment. It's not like a patient with cancer that knows what's the meaning of the disease and how we should act. But since the brain is the window to our reality, if this reality is twisted, then everything is wrong. So the implications of the disease are horrible not only to the patient themselves, but also to the entire family. The numbers are really staggering. We are talking about diseases that, for instance, 26% of the adult Americans require psychiatric help each year. We are adding here not only really psychiatric, or the major psychiatric diseases, but also attention disorders. But if we remove them, we are left with something in between 4 to 6 or 8%, which is again too much. In many cases, our treatments don't work well, and whoever knows a mental health patient knows the long process of trying to optimize the exact prescribed medicine, the exact dose. The costs are really horrible because in many cases it's a disease that attacks a person in his prime of his life. Like a person now in college gets the first bipolar disorder, episode, or depression. And these are the years after he learned that he should be productive, that he should be a taxpayer, that he should have a family. The costs of mental disorders are the heaviest social and economic burden on societies, even more than cancer or cardiovascular diseases. For instance, this is the number of the estimated cost by the World Health Organization, the cost of mental disorders in 2010. 2.5 trillion is the number. The thing is that prevention can be done much easier if you catch the disease at an early stage. In many cases, if a patient has a very good family, a very well controlled with very good relation, it can help. A mother or a spouse can call and say the patient, talk to the patient itself or to his psychiatrist and say, I think that something starts, and the thing might be resolved easily. But if it's not this case, then the costs and the price, not only in cost but social and life quality of life price is really horrible. I give the example here of a bipolar disorder. Okay, you have a manic phase. It can be very strong. This is a very joyful phase in a sense. You're in euphoria. You don't need to sleep. You sleep for 2-3 hours. Then you work for 15 hours. You go to a bar. You go to another restaurant. You have time to call to all your friends, and you are fully energetic and euphoric. But then you might fall down to a depression, which can be horrible. And then you need to come up. To get over this episode. And again, this could be related afterwards to hospitalizations, and the cost of every day of hospitalization is really huge. If you catch the disease early, there is a prodromal stage in which the disease is really benign. It's not fully blown. If you catch it at this stage, then even just a change of a prescription, in some cases even just a sleeping pill, can make the entire difference. And this is what we want to do. We want to help change this thing by aiding the psychiatrists. The psychiatrists monitor their patients. So the idea is to develop an expert aid system that will assist psychiatrists in detection and prevention of recurring illness episodes. 3 minutes. Okay. So we want to do something that will be based on a fully transparent smartphone application. And the idea is the following. We'll have an Android application that will acquire data about the patient's behavior. We'll have algorithms for signal processing and for analysis of the data and gathering from the analysis behavioral data. And we will have a web-based system that will allow the psychiatrist every morning, just as your MD clinician every day looks at the blood tests of the patients that he sent a day before they returned from the lab. In this case, we will look at the behavioral parameters of his patients. So the idea is to use all the sensor of the smartphone, and it's not only a microphone, it's not only a GPS, it's an accelerometer, a sensor, a light sensor, and so on, and I don't have the time to go through all of them, and from them extract important data for the psychiatrist. Data about the sleep, about the spatial mobility of the patient, about the social interaction of the patient, about the vocal characteristic and speech characteristics of the patient. And take all this data by maintaining complete user privacy and by doing something that doesn't involve any intervention from the patient. And I won't get into details, but if you have so many sensors, you can really detect all the time everything that happens. I can tell here when the lights goes up and down, when somebody is moving up, walking with his smartphone. So we already have 2 Helsinki-approved clinical trials taking place in the Gea Hospital, and this is headed by Professor Avi Weizmann, in the Bayer Yaakov Hospital with Professor Horwitz, and we now set another trial with the Ramat Chen Clinic. We have already 20 patients and 20 healthy individuals that have these smartphone applications installed on their smartphones. And let's look at the data. I'll just give you a few examples from our pilot's experiments. In this case, what you see in the x-axis is time. So this is like 3 months. This is 24 hours. This is noon again for 1 day, second day, third day, and so on. A dark blue color means no activity. A light blue relates to various degrees of activity. So for instance, each of you can easily see the pattern of sleep of this person. This is the time where this patient sleeps. There's no activity. We can see it easily. Moreover, you can see that every 7 days, this patient has no activity. This is a Jewish Orthodox. And you can even see easily how Passover is here with many days of no activity. And when you take something like 5 weeks earlier, you can see the party of Purim. This is it. This is you. Now let's see a different patient. This is another patient. Again, this is the pilot stage, not the blinded studies that we also perform. Again, you can see the sleep. You can see that in this time something happened. There was lots of activity during the night, sorry. We were afraid this could be a sign of something like a bipolar thing. The psychiatrist called the patient, said, don't worry, I have a new boyfriend. And he was in some of the time also abroad, so things are good. This is for good reason. The amazing thing is that she was really happy with him calling her. Some of the patients really want the attention of the psychiatrist and they don't have enough of it. And now let's see something more interesting. This is a patient that has a chronic depression. And what you see here is that we notice that in this period over here, there's much less activity. And during this time he was abroad. But then during this time there's much less activity, much fewer activity during the day, and even the nights are longer, okay? So what we did was we started, and you can see just a glimpse of the analysis that we do, and look at, for instance, how much communication is going out from his smartphone every day. And you can see that during these days there was a drop in the degree of communication. There was his speech characteristics change. In each conversation, he was speaking much less. It wasn't usually in a conversation with 2 normal persons, it was 50-50. Split in the amount of talk, unless you're talking with someone who's really drilling in your head, as we say in Hebrew. And then what we do is that we don't rely, for instance, for this case, his mobility didn't change. This is a guy working independently, and in many cases he's at home. The important thing that I want you to see, with the 1 minute you gave me, after an extra that I noticed, is that every person has his own pattern. For this person, the mobility is not important. I will look at these 2 parameters and other parameters. The important thing is that I compare each patient to himself, not to a norma of the society, okay? So last module is the web application that we give the psychiatrist. Psychiatrists can enter any morning either with an iPad or a laptop, and just look at each patient. These are just volunteers, students, don't worry, they are healthy volunteers, and see 7 days, and within each day, is there a significant deviation from the norma? Okay, this is just an example. So for instance, you can see that Karen Sella had deviation in her speech, but this was only in her speech and only for 3 days. There's no reason to be afraid of this thing. And then if you want, you can plug into more details about a certain patient. And okay, I won't get to it just because of time, but the patients themselves, we had one patient that removed the smartphone application, and when she was hospitalized, she said, you would immediately know that I was going to become, I was entering a manic episode. So our advantages are really that we use no additional or hardware wearable sensors. Yeah, there's no wrist, no button, nothing, just a smartphone itself. There's no user intervention. It's a weak measurement with multiple dimensions. And the smart thing here is to use this weak measurement, but over long times and over multiple dimensions, this way to really find something meaningful about the person. I won't talk about all the things. We have challenges. This is a continuously growing and highly dynamic market. We don't really know what will the pattern of behavior during the prodromal stage. We need to find it when we'll get into patients that undergo such a phase. And we try to think of the exact way to put this thing into the psychiatric practice. Last word, when I talked with Yesha, when he asked me to present this work, he said, maybe this is the one end of the spectrum of deep innovation. Okay, this is not the thing that Ina or Danny Michelson do. I do other things that I think are more deep but are less applicative, but we'll talk about some other time. But we believe that we compensate on the lack of deep innovation here, and I believe this is something that could give results within a year by really a very strong deep need, and that could make aid to tens of millions of patients. And that's it. Thank you very much.
This program was brought to you by Koller Institute of Venture at Tel Aviv University.